So I'm Kristina Mirabeau-Beale. I'm a board-certified radiation oncologist practicing with 21st Century Oncology in Southwest Florida, and I'm based at the Regional Cancer Center and part of the Breast Program Leadership Program. COVID-19 has very much impacted our cancer care day to day in ways that are unprecedented. Um, Cancer generally is considered an essential service, and now we are forced to kind of reevaluate every patient's cancer decision making against an imminent infection risk that's also putting a strain on our healthcare system day to day. So I meet patients at different parts in their journey. My priorities now are to safely finish the patients I have currently undergoing radiation therapy, and that involved streamlining some of our procedures in our department to make sure that those patients can finish treatment with minimal exposure risks, to also continue to follow up patients who recently completed treatment, and now in terms of streamlining how we're able to follow up those patients in the setting of some strain in terms of fewer staff members as folks had to quarantine after travel exposures and those sorts of things. And then, of course, the new patient diagnoses and thinking which patients need to start expeditiously versus which patients can safely delay their radiation, maybe by going to chemotherapy. And so all of this is causing us to really have to rethink our standard treatment algorithms and patient paradigms while weighing an imminent infectious risk and the desire to keep our patients or support our patients in staying home. So a lot has changed for my patients in more some of the community spirit, I'll say, of being a community oncologist. So normally our waiting room is a very pleasant place where there's a coffee machine, there's refreshments, there's puzzles, there's a number of folks there who start to see our treatment center as kind of a place where they have a community of support. Now to minimize the number of folks in the department and obviously items that can be sources of contamination, we very much streamlined and sterilized our both waiting room and changing room. We have patients wait in their car, for example, and our therapists call them back to be treated during their designated treatment time in an effort to really minimize the number of people in the department and number of patients who are in and out of the department at a given time. Another difference is the utilization of telehealth. And so a lot of times patients would meet me before their surgery, for example, as we see patients in part of our multidisciplinary team. Now we tend to only see patients when they actually are at the point where they need treatment. So for example, after they've completed chemotherapy or after their surgery. And other patients I'm seeing via telehealth format to kind of introduce the role of radiation, but before they're ready actually for treatment rather than having them in the department. And I think that while it's still helpful, and it does lose some of that human connection. I've found that even for some of my patients where we're about to start treatment, it's obviously very different to convey compassion through a mask. There's some degree of facial expression and empathy that's lost. And then, of course, even simple things like being able to hug our patients as they hit rough patches emotionally during their treatment. That's definitely been something that I've noticed, at least something that fulfills me as an oncologist. I've felt the I guess emotional toll of social distancing when it comes to dealing with such an emotionally charged specialty like oncology. I find that even though, we tend to focus on our specialty, and I'm an oncologist, a radiation oncologist, I try to stay as up to date as I can on all the changes with COVID, both in terms of community incidents, our hospital systems surge plans, and protocols around testing, because that's what patients are concerned about. They come to me to ask about radiation for their breast cancer or their lung cancer, but they're also asking, gosh, I went on a cruise a month ago. Do I need to get tested? My grandchild may be visiting. Should they be involved? Should they be allowed to visit me? Can my spouse come in with me during my appointments? And all of these things very much depend on us as physicians to kind of all feel solidarity with our colleagues on the front lines and know the right questions to ask. And then also understanding kind of patterns of spread and measures we can do to mitigate exposures to our patients, so we can also affirm some of those guidelines, like the CDC's new change to wearing masks and when out and about in the community, and just emphasizing what it means to social distance and why it's important. So I find I'm wearing my primary care and my urgent care hat a lot more, in addition to wearing my radiation oncology hat. And then, of course, for some of my colleagues who treat patients who have more issues in terms of lung cancers and head and neck cancers, where to do scopes and things, there's a risk of aerosolizing droplets. That enters a whole issue in terms of protective equipment for staff and physicians and patients during those encounters. So we've really had to rethink kind of our day-to-day in a way to be more generalists, I think, and also infection, not experts, but at least more concerned with the infectious disease component and how it affects our practices. How can we work together better? Well, I think some of it is I've been actually really impressed with kind of real-time responses that a lot of professional organizations within medicine have responded to the COVID crisis. So in radiation oncology, ASTRO, our professional body, not only published some very timely pieces that described some radiation clinic experiences in Italy and in Wuhan that was extremely helpful in terms of thinking how practices can change their patient throughput and triage in such a way to minimize risk to the patients and to their staff. And so being at the cutting edge of publishing those data so they can reach more folks and we can learn from the experiences in other places that were hotspots of the early movement of the pandemic has been very important. I think in addition to that, consensus statements, ASTRO and also the Society of Surgical Oncologists, for example, and I'm sure ASCO as well, have published different guidelines in terms of how we can triage certain patients based on diagnosis safely, that kind of in aggregate look at the data to see if there are compromises to oncologic outcome, and providing reassurance where we are able to say a patient can safely take an aromatase inhibitor for 3 to 6 months and delay their breast surgery if need be. So I think our professional societies, in terms of disseminating that information in the form of guidelines and practice bulletins, has been very helpful. I think another thing we can do to improve is kind of formats like this, where now there can be an audiovisual component, kind of like an evolving continuing medical education briefing that as practicing clinicians we can tap into. And so also there's crosstalk between specialties so that we can see how best practices in medical oncology, for example, can inform some of the things we're trying to do in radiation oncology. So more communication, continued communication as we all work through this together, I think is very important. Something I'm still figuring out day to day in my clinic is kind of creating other support systems for my patients in the absence of kind of that community of patients and the physical interactions that we're able to have. I think in some sense now that we can do telefollow-ups, some of my patients who maybe couldn't see me until I was at a given clinic on Monday or Wednesday now feel that they can reach me on any day because we can just set up a televisit. And in that sense, I'm more accessible. But then it's the subtle things like, I delivered some bad news to a patient who had new brain metastases, and having to tell somebody that their prognosis has changed and the treatment I'm about to give them now is going to cause such side effects through basically a fancy FaceTime conversation, and watching the tears roll down her cheek and being unable to give her a Kleenex and hug her. That felt very haunting to me, and I'm not sure how we're going to be able to overcome that necessarily, while we still have to maintain distancing and while there's still a lot of unknowns. But I'm very hopeful that I think through this pandemic and how the medical community and kind of activists of social justice and just regular citizens who feel empowered are kind of thinking outside the box, that this can be a time of clinical innovation. And maybe some of the things that we adapt to work around COVID may end up improving some of our clinical practices. So I'm hopeful we'll be able to grow from this, but I definitely wish I could convey my sympathies and empathies for patients in a way that felt more tangible than I can sometimes do when we have to maintain 6 feet of distance.